Live.
Yes.
Hello, everybody. Greetings from Confederation of Medical Association of Asia and Oceania. I'm Dr. K.K. Agarwal, President CMAAO. Welcome to our 31st meeting. And I welcome Dr. Mathanda Pillai and Dr. Jamaluddin Chaudhary, Dr. Meenakshi Soni, Dr. Sanchita, Saurabhji, and others who will be joining. I'll request Dr. Mathanda Pillai to chair this meeting. And, when Dr. Chong comes, then both of them will chair this meeting together, because every time along with Dr. Chong, we elect one person to co-chair the meeting. Dr. Marthanda Pillai is a past national president of Indian Medical Association. He is also a council member of World Medical Association. So today's topic, till other people join, is update on what we discussed last time. And then we will talk about one more concept which will be of help to everybody. So what I'll do is, so last time we have discussed about various graphs. This is just to update. These are updated graphs from last time. You can see when it comes to daily new cases, and you can see it is in the word, you can say this is a single wave, or in the word, you can say it is a third wave in the whole world, because you can say a type of a very small wave going on 2 and 3. You can also call it as a single wave. But if you see the mortality is going down, increasing, going down, and increasing. That's what the word mortality is. When it comes back to India, we see here there is only one wave. With that wave, mortality is also peaking the wave. There is a synchronicity between the daily new cases and the deaths. This is how you are going to see in India. In India, I want to show you that total national, there is one wave, but in various cities, you may have multiple waves. So the wave of the world may be different from the wave of a country. Wave of a country may be different than the wave of a city. Here you can see Delhi is showing third wave. Maharashtra is showing only one wave. Kerala is showing the second wave. You can see Odisha is showing only one wave. Bihar is showing only one wave. Rajasthan is showing only one wave. Karnataka is only one wave. We come back to USA, and if in USA you will see three waves. But if you see in three waves, the mortality is reducing. So in the first wave, mortality was very high. In the second wave, mortality was low. In the third wave, mortality is further low. That's what USA pattern see. If you see Peru, the second wave is bigger than the first wave, but the second wave has a lower mortality than the first wave. Russia, the pattern of cases and mortality is the same, exactly the same graph. Iran, you can see the same graph, second wave, third wave, and you can see mortality also following the wave. UK, you can see just the reverse. The second wave is the mortality in the first, right side is mortality, first side are the cases. You can see a replica. In the first wave, mortality was very high. In the second wave, mortality is very low. Italy, again, you can see like UK. So all UK countries are following one pattern. The mortality was very high in the first place. It is very low in the second phase. Spain, again, the same thing. So all European countries are following one particular pattern. South Korea, you can see both of them are identical. Both the waves show the same types of mortality. France again is showing more like a Europe, which is a part of the Europe. And you can see in France also the mortality is lower in the second wave. This is Brazil, only one way, mortality and the graphs are same. Pakistan, the graph and these are same. Now, if you see at this, maybe the Pakistan is going for a second peak. If you see here, the cases are started rising. Maybe in the next 2 weeks, we may find Pakistan going for a next week. Bangladesh is having the first peak only. No second peak has come. But maybe if you see here, the graph is started rising like Pakistan. Maybe that in Bangladesh, you may start getting cases again. In Singapore, we see that mortality does not correlate with the cases. The mortality is very low. China, again, the second wave has not come. This is Saudi. Saudi, again, you can see this behaves more like a UK. The first wave is small, second is bigger. Here, the mortality is slightly different. Then we come back to Australia. We can see the first wave, there was no mortality. The waves and mortalities are going the same way. In Nepal, we can see the same pattern of mortality and the wave. They are almost behaving the same way, Nepal. The interesting thing is Lanka, we can see the second wave is bigger than the first wave and the mortality is also bigger than the first wave. Any questions on this? Then we come back to this is we have decided to update every week. Up till this portion, we will be updating every week. Any questions on this so far?
Is it Dr. Agarwal? Good morning.
Yes.
We can hear. Is it because they already with this anticoagulant measures are taken and anticoagulant drugs are given, and that
In a country
because
by
the
country,
postmortem actually.
in a country by country, the patterns are slightly different but predictable, because all European countries are predicting the same way. All Asian countries are predicting the same wave. So what I am trying to say is that the predictions are there, so they are matching with the mortality rates also. Now here is a matter of discussion to decide what can be the reason. Okay, so there we are seeing three patterns. One pattern we are seeing is there is a gap of 2 months between two waves. That means in a Europe model, we are seeing there was absolutely zero cases. Zero means practically zero cases. After 2 months, cases started rising. In India, Pakistan, and Bangladesh, USA, we are seeing that in between the cases never become zero. Mortality, somewhere it is reducing and somewhere it is increasing. It is following the same pattern. So I want to come back to the second part now. I want to come back to the second part, but before
No,
that,
but the question is that I was just raising this. You are showing two examples. Lastly, that their mortality is increasing, and it is more than the first wave.
no, yes, no, but
I
the
saw.
number. See, let me share. Which
South Korea,
country?
South Korea, South
Which
Korea,
country? I'll give it.
South Korea, Iran. You're telling South Korea.
No. There, for example, Australia. This is following the same pattern. They are following the same pattern as that of. They are following the same pattern as that of number of cases, like South Korea. Their mortality, first one cases was high, mortality was high. Cases reduced, mortality reduced. So they are following the same pattern as the first wave.
But you are telling about Iran, I think. I don't know
Iran,
exactly.
Iran also is
This
following the same
Iran.
pattern. The
Same
pattern is
pattern,
the
no?
same.
Same means
More the number of
case.
cases, more the mortality.
Oh, that's right.
These are interchangeable graphs. Now, before I go further, I had invited the WMA president in one of my presentation. So I want to share what he has to say about CMAAO. Show all windows.
I would definitely like to study and get the scientific
Amount of fear the Saudi Arabian countries have, you cannot have it in China. China still is a democratic country. What I am only trying to say is maybe that the answer lies will at WMA. I don't know whether it comes to their domain or not, but WMA can be a neutral partner. Try to understand, because WHO, US are fighting. WHO, China status nobody knows. China is not allowing anybody to enter for finding out what the truth is. But maybe, I don't know whether it comes into the domain of WMA bylaws or not, but World Medical Association can. I have, at a CMAAO level, I have been president. So I want him to say his message for CMAAO countries, which I will be able to present it on this Saturday morning in the morning. So I will play this video, I will play it in my CMAAO meeting. So if you can address now as CMAAO countries, what is your message?
Well, thank you very much. I applaud how organized you are across the CMAAO countries. You really set the standard for other countries around the world. For instance, I tell you, I am envious. We do not have that same sort of thing for the United States or for the countries of the Western Hemisphere. We don't interact as well as we should with the other countries. So I think you do an excellent job, and it should help you spread best practices as quickly as possible from the medical and clinical standpoint. But I think it also helps encourage your professionalism, and you support one another and you encourage one another. And that is really quite impressive. And it is, again, something that many other areas of the world simply do not have. And so I commend you for that. I commend you for the work that you're doing under extremely difficult circumstances now under COVID. Our profession is hard enough under the best circumstances. We face challenges all the time, clinical challenges, infrastructure challenges, health inequities and health disparities in our country. And now these have all been magnified by COVID. So I will tell you that I am just very encouraged by what CMAAO does. I strongly recommend and hope that you're able to continue this under these difficult circumstances. It will benefit our patients, your patients, and it will benefit your colleagues. Thank you very much.
Thank you, David, for your very nice comments. So this was the message by WMA President for the CMAAO. So he said he can't imagine that CMAAO countries have been meeting for the last 30 weeks together. He says we can't even dream of this in US and European countries because they don't talk to each other. That was his message. And on this Monday, we will have Dr. Chong addressing us in my evening show. One by one, I will be calling all the office bearers and we will be interacting with them. So his message was very clear. He says, I feel envious of CMAAO that they have been able to meet every week, discuss on various points. So our chair has joined. Now our chair and Dr. Jamalu Chaudhary and Dr. Marthande Pillai both will be chairing this. So Dr. Chong, I am just going to, because you have joined slightly, I will just update. This is what I have promised that I will be updating every week. This is we have decided. No, this is not this. I have to go to. Where is that? So this is just to quickly update, then I go back to the session. This is total word. Word is showing 3 waves, and the mortality is also following the same pattern. With every wave, mortality is increasing. This is India. You can see on the left cases, on the right death. Death and wave are following with the same pattern. This is inside India, Delhi showing 3 waves. Country may be showing first wave, but a state may be showing a third wave. And then we come back to USA is showing 3 waves, but you can see the reverse pattern in mortality. With every wave, mortality is showing the reverse pattern. Peru, again, mortality is showing the reverse pattern. Russia, following the same pattern as number of cases. Iran, following the same as number of cases. If you can see UK, it is reverse. Number of cases less, mortality more. Number of cases more, mortality less. Italy follow UK. Spain is following UK. France is following UK. South Korea is following UK. Brazil, only 1 wave. They're dicto the same. This is Saudi Arabia. You can see mortality and number of cases are same. Pakistan, we can see only 1 wave, same mortality pattern. Nepal, you can see same mortality pattern. Bangladesh, same mortality pattern. Singapore, you can see hardly any mortality. China, you can see hardly any mortality. Australia, you can say as the mortality is reducing, but the pattern is the same. Sri Lanka, now we have started seeing cases. Otherwise, it was absolutely without any number of cases with that. So with that, we have already covered. Now I come back to one more study which I just wanted to share. And we have been talking about in our CMAAO guidelines about mouthwash. And now a journal of dental research has come. Very clearly, they have written that we use 3 doses of antiviral mouthwash the day before meeting and 1 dose in the morning of the meeting. So they are talking about that if we are practicing, we should do a Providon iodine mouthwash 3 times in a day. Now coming back to the subject today is early anticoagulation. I want to say this with affirmation that if we follow this 10 minutes discussion, we will be able to reduce our mortality substantially all over the world. Hypercoagulable state is associated with acute inflammatory changes. It is associated with high fibrinogen and high D dimer. What they are saying is it is present in 25 to 43% of ICU patients. It is microvascular thrombosis. Now see here, all inpatients should receive thromboprophylaxis unless contraindicated. Now when I spoke to Dr. Barbie, the WMA president, and he said in US, home quarantine is not allowed. In US, they are still following all admitted. That means practically everybody is receiving thromboprophylaxis unless contraindicated. This part I want to emphasize more and more. That means every patient should receive thromboprophylaxis. My discussion is based on 2 points. Point number 1, if you give aspirin to everybody who is high risk, or we start oral anticoagulation on day 1, if he develops a COVID-19, you may not require any other treatment. The disease may become self-limiting. Now, this is a study about antiphospholipid antibodies. Now, remember the second line. COVID is self-amplifying cycle of inflammation and clotting. It is self-amplifying, means inflammation begets clotting, clotting begets inflammation. So this clearly talks about recurrent inflammation, not relapse, not recurrent infection. So he says the main pathology is recurrent self-amplifying cycle of inflammation and clotting. And they say that 2/3 of the patients have APL antibodies requiring anticoagulation with that. And they say that dipyridamole, if available, may be a good enough medicine in such cases. Now, I want to come back to a little bit on C-reactive protein, my and our observation in CRP. The CRP will begin rising in 4 to 6 hours. It will double every 8 hours. It will peak at 36 to 50 hours. That means by 4th day, CRP should come back to normal. So there are 4 patterns of CRP. Some patients will be fast response pattern. So we say by day 4, if your CRP is 0.4, which is baseline, you have recovered. Some people will recover by day 8. They will have their value on day 4 will be 0.8. That means double than the baseline. They are slow pattern. Then they will be non-responder where CRP continue to rise. And biphasic response is what I have spoken about. Recurrent, this terminology, when I say self-limiting cycle of inflammation, means a biphasic response of CRP. Now, I want to come back to CRP. Now, these are the cutoff values of CRP. There are lots of references available. So we have a cutoff value of 0 to 10, 10 to 20, 20 to 40, 40 to 100, and more than 100. These are the references available. If your CRP is more than 10, take it for granted the patient has pneumonia. If your CRP is more than 10, the patient has pneumonia. So on day 3, day 4, day 5, or day 8, if the CRP is more than 10, patient has pneumonia, start them on anticoagulation immediately if not started early enough. So these are the cutoff values. Most of the people agree a cutoff value of 10, which is 11. Then they have 26, then they have 40, and then they have 100, depending upon the severity of the disease with that. So these are some other parameters, but I'm basically discussing the parameter only of CRP. So what we have seen is if you want to reduce the mortality, follow only one test, and that is C-reactive protein. The data says CRP rises before CT scan changes. CRP rises after ferritin. So the first one to rise is ferritin, second one to rise is CRP. And if the CRP is rising, and if it does not become normal by day 4 or by day 8, you are heading for a cytokine crisis. If you can prevent a cytokine crisis, you have preventing one death and hospitalization. So the parameters and our observations are, number 1, that if the patient has a underlying CRP of 1 to 3 before he develops corona, that means a CRP of 1 to 3 means mild inflammation. So if a person has mild inflammation with a CRP of 1 and 3, he should be immediately put on aspirin prophylaxis. So all such cases whose CRP is between 1 and 3, they are day 0, they have not suffered from corona. They should be given aspirin prophylaxis. Add a statin if their LDL is more than 70. If they develop a disease, and if you can shift from aspirin to dabigatran or rivaroxaban, that is on day 0. And on day 3 onwards, if you find any evidence that the CRP is not returning back to normal, you add steroids. And if you do that, you may be able to prevent a cytokine crisis. So my hypothesis today is cytokine crisis is preventable, it is predictable, and if you can prevent it, you are saving one life. I am also predicting the future. In future, someday some people will come back and say, if you are taking aspirin before you develop corona, you may not end up into clotting at all. And my third prediction is, if you give early blood thinner on day one, the day you suspect or get for your testing, you may not be able to need even steroids in such cases, because steroid will only come when there is a microclot formation. The role of steroid will only come if there is a microclotting formation. It reminds me of my own practice for the last 30 years. All those people who want to go for a travel to USA, when they are traveling more than 8-hour journey, and if they say we have an underlying hypercoagulable state, I have been giving them rivaroxaban or dabigatran before the travel to cover up for the travel to prevent economy ward syndrome. In such a situation, a drug which is anticoagulation, which is so safe, which can be given easily for 2 to 3 weeks, if you give it, you can prevent a person going into cytokine crisis. So today's topic was cytokine crisis can be predicted and treated, not treated, prevented and subdued. That's what my topic was. Hand it over to Dr. Chong and Dr. Mathanda Pillai.
Thank you, President. I believe Dr. D'Souza is chairing us today for some discussion. Is that right?
Yes, yes, yes.
Yes, thank you, KK. Yeah, well, I took that Dr. KK told me this. I spoke to Dr. Chong and Dr. Jamal, who yesterday we had a talk, and I think Dr. Chong is going to update us on what's been happening, the experience that they've had in Singapore. And I think Dr. Jamal, were you able to pick that up?
Actually, sorry. No, I just sent a message to Dr. Hagawa. Actually, probably it does not come into notice. So I could not get anything from there. So I couldn't recollect also what was actually we were discussing in the last meeting. So Dr. K. Agarwal, in that some point, he was told that you will be chairing the that session and we'll discuss. I couldn't recollect. Sorry.
Go ahead, Dr. Chong.
Yeah, Dr. Chong, can go ahead, Dr. Chong.
Okay. I'd just like to thank you very much, President and Dr. D'Souza. Always a pleasure to join all of our CMAAO colleagues on our Saturday meetings. And it's very interesting. I just saw my dentist a few days ago, and they made me do a mouthwash before and after the treatments. So I think it was relevant to what President had just mentioned about mouthwash. And apparently this is now a policy in all dental clinics in Singapore to do the mouthwash prior to the treatment and after the treatment. So very, very interesting little tip there. I'd just like to share screen just to give you an update on what's happening. I'll just share screen right now. Sarab, can you just let me, thanks. Sarab, can you let me share screen, please? Thank you.
Yes, you're allowed. Yeah.
Thank you. So this is our latest update of our situation in Singapore. This is our ministry website, and you can see that to date we have 58,000 cases. Most of them are actually our migrant worker cases. Can you all hear me? Okay.
Yeah.
Can you all see the screen?
Yes.
Okay. Most of them are actually of the 58,000, about 2,000 are community cases. The rest are unfortunately our migrant workers, and you can see that the number of demise is 28. Is steady at 28. In fact, our COVID deaths for this year is 28, but our dengue deaths for this year is also 28. So honestly, in Singapore, our dengue problem is just as bad as our COVID problem. And unfortunately, one of the problems with dengue was because most of us were working from home. So the mosquitoes had more human beings to bite during the day. So very, very unfortunate. And this is, can you all see this table?
Yeah.
This is our website from our Singapore Ministry of Health. And you can look at this, the last few days, and look at our community cases is really 2 to 0. So total community cases is really only 2,270. But if you look at our migrant worker cases, it's 54,000. So the balance was migrant worker cases. And fortunately, in Singapore, the migrant workers were fit, young, and healthy. They have a lot of stamina because they work very hard. And so as a result, we did not have much ICU admissions from the migrant workers and very little need for oxygen. Our local figures show that if you're 35 and below, only 3% need oxygen, 0% need ICU. This is compared to 60 to 69 years old, where 55% need oxygen and 36% need ICU. So it's really a dichotomy if you look at the young and the old. And you can see right now our biggest problem are imported cases, and they're coming from all over the region because we still have people coming home to Singapore. A lot of our Singaporean diaspora is overseas. We have a few 100,000 people scattered throughout the world, in particular Asia, and a lot of these people are returning home. So unfortunately, we still have the imported cases. However, we have, when they come from the airport or the seaport, we ship them directly to a hotel where they serve the stay home or the quarantine for 2 weeks before we release them. So if they become positive, we know exactly where they are and they have no chance to infect the community. So this is what's been happening in Singapore. And the biggest challenge really now, I'll stop my screen sharing. The biggest challenge now is really opening up the economy. So this is our biggest challenge because our airport is really crucial to our economy. And right now we have a whole series of arrangements with various countries. For example, we are trying to establish a bubble, what we call a travel bubble with Hong Kong, where if you just swab and you can just come in and out, and we can just go to Hong Kong and back and forth without any quarantine. We also have unilateral arrangements with certain countries like Australia and New Zealand. However, they have not reciprocated bilaterally, if you know what I mean. So for example, if people are coming from New Zealand or Brunei, we are not worried about them. We do not quarantine them. However, if we are going to New Zealand, we are still quarantined by the New Zealand government. So we have a lot of unilateral arrangements, but unfortunately, some of them have not been reciprocal. So this is in fact our biggest challenge because we only had one wave really. That was, we had the initial outbreak in a community where we had to do a lockdown, followed by the outbreak in the migrant workers' dormitories. Now, the migrant worker dormitories have kept us on our toes throughout these few months. And it's only in last month that we have managed to bring the migrant worker dormitory outbreak under control. But in a way, I see it as a silver lining is that if we had just had the community cases 2,000 plus, and we open up our economy, we will have a second wave. So in a strange way, the migrant worker community was a kind of a silver lining for us because we ended up just having one big first wave and we did not have a second wave. So now our problem is reopening the economy and fearing a real second wave from outside. So these are in fact our challenges. Our mortality has been kept low, and whatever figure you use, whether is it a 58,000 or the 2,000, it's one of the lowest in the world. And we attribute this to very good ICU care. Fortunately or unfortunately, the year before this crisis, we built a new national infectious disease center, state-of-the-art building, 300 bedder, can expand to 500 beds anytime, with 300 isolation rooms and so on. And we thought initially it would be a white elephant, but COVID came, and now our investment in the new infectious disease center has paid off in spades, because it became an epicenter of handling the COVID crisis. Literally 60 to 70% of the COVID cases were handled in that one center. So that one center, if had done very, very well, and hence we believe that it's why our mortality figures are low. We are now distributing tokens to the whole population. These tokens are electronic tokens. They will allow instant contact tracing the moment we identify anyone. We just download the contents from the token, and there's privacy because we won't need the token unless the person's become positive. We're in the midst of distributing a few million tokens to every every citizen and PR, everybody living here. So we'll know exactly. We don't have to do intensive, labor-intensive contact tracing. We will be able to do electronic contact tracing immediately when we identify a positive case. So that's being rolled out. In the meantime, as this is being rolled out, we are using certain apps that we have on our phone. And these apps are also similar to the electronic token, but the electronic token obviously will be much more efficient. So this is what we're doing. So many measures going on to try to contain everything. But the biggest challenge, honestly, is opening up the economy and fearing the second wave coming in. So that's all I have to say for the time being. Thank you very much.
Can you explain the electronic token, more about it?
Yes, this is an electronic tokens that we are trying to send to. For example, in Singapore, we have community centers in every constituency, political constituency. There's a community center, and the citizens can go pick up the token from the community. It's a trace together token. I try to show you a picture of it, what it looks like. I don't know whether you all can see, but this is what it looks like.
Okay.
Okay, so this is an electronic token, and every citizen or PR in Singapore will carry one, and it allows for privacy. You don't need to access it unless you're positive. If you're positive, they'll take the token from you and they'll put it into the computer, and they'll spew out all the contact tracing, because these tokens will all talk to each other. So anybody holding a token the two tokens will make a record of you meeting each other. So instantly all the data will be downloaded.
Excuse me, can you show us again? Show us again the token.
Yes, I will. Hang on.
And it's a WhatsApp, is it like a WhatsApp program or what?
No, it's actually a physical token.
I see. Everyone carrying it?
Yes, we intend the whole population to carry it. Everybody carry one. So all these tokens are, you can see, it's just very small. You can slip in a pocket or hang it around your neck. And in particular, we find this very useful for elderly. They're not so good with technology, with phones and so on. Right now, all of us are using what we call safe entry token. So we'll take a picture. We'll use a QR code. Every time we enter a shopping mall or something, we have a QR code. And when we snap a QR code, we have this safe entry identification. And we have to show this to the security guard before we enter the mall or enter a clinic or enter any premise. So all of us are supposed to scan a QR code. There'll be a QR code at the premises. You scan the QR code, and this is called safe entry. So this has been going on for the last few months now, but we intend to make it easier with an electronic token. So I think they've issued about 500,000 tokens. We have a population of about 5 million. Eventually, 5 million of us will have a token. They estimate that if half the population carries a token, it'll be enough. But I think we're going to make it mandatory for everyone to have a token. So it's being rolled out in phases.
And for the QR code, is it just like a G5 communication technique?
Yes.
Is it
Yes.
G5?
5G? No, it's not. It's not 5G. It's just a QR code. A QR code on the premises.
What
on
about the token? Yeah, also the token.
the token, I'm not sure whether it's 5G, but the token apparently talks to each other. They all the tokens talk to each other. So if the two of us are wearing a token or carrying a token, the token will record the fact that we're near each other.
I see.
So, Dr. Chang, we've got, they introduced in Australia an app which works on Bluetooth, and that's, similar way in that it talks to each other and so forth. But the thing is that you need a certain amount of people to use it.
Yes.
And they couldn't make it mandatory for various reasons here. But yeah, so that was introduced, and everyone's supposed to use that. On the other side, just to tell you from in Australia, it's a rather, KK was showing that graph. But the funny thing here was that there wasn't really there was the overseas quarantine failed, and the quarantine ended up with this what do you call it only in one city or state, and anyhow that's all been now under control. I mean, they had a what do you call judicial inquiry. They've not had for over a week. There's been zero, no cases at all, and of course they've started flights with New Zealand. That's going on now, and Melbourne, which was closed, is open to New Zealand from next week. And but the thing is that yesterday they've come out with some 49 new issues how to do your quarantine. Okay, they have a whole review. There was a big what do you call it inquiry. So they are now talking about hotel and even house, but using GPS bands and so forth. So this is in preparation for the quarantine and so forth. But again, it's open in the sense the businesses and those things are all, and states are also here. The borders also are closed, so that's also now all in the process of being opened up, because they've sort of had 7 days or more, and they're waiting for more zero case for the last few. And the what do you call it? The testing is still 15,000 to 18,000. But I think ultimately, the only way we can know is if we do random testing, not just symptoms, isn't it? We have to pick people up randomly and test to see what is the community. What do you call it? What's the virus available in the community? They're talking about. That's the next thing that they might try to do.
Okay, I'd like to show. Thank you, Dr. D'Souza. I'd like to show you all. This is the Trace Together app that we are all carrying in our handphones. So this is a Trace Together. It works like a token, but initially when it was launched in Singapore, there was a lot of problems because the Apple phones wouldn't allow. The Apple technology would not allow the phones to talk to each other through this app, because the big tech didn't allow us to do that. So we had a lot of problems, but I think it's been solved between our government and Apple. So we call it Trace Together. That's what we're using, all Trace Together, and it works like a token.
You see, that's the one in Australia, and they use Bluetooth. You have to keep your Bluetooth on,
Yes,
and it'll tell you every day. Like what's the number, what all the data is there, but I think it uses Bluetooth. Yeah, so that's what's the national. It gives you up to date what's happening up to the time.
Also, very interesting. If you use a Safe Entry and this Trace Together app, they will tell you in the last 1 week where you went, whether there were any cases, for example. So they will also alert you that, look, there were cases in the places that you went. So this is So I think it's all many things going on. It's contact tracing, there's apps, there's tokens, there's restriction, social distancing, masking. I mean, it's really a concerted, multi-pronged effort to try to bring everything under control. I'm quite aware of the situation in Australia because my son is in Monash doing a residency there in psychiatry. So he keeps posted what's happening there.
So,
And,
Dr. Chang,
yes,
I have a question to you.
sure.
That you are telling the same thing which I had in my mind, that why Singapore has having so less mortality, or knowing the fact that you have got a very sophisticated system in health system. So, but I have a question that whether this has started from the point that the anticoagulant has started actually, and that this is the mainstay treatment. That it has been afterwards, or before that also you had some people having this COVID-19, and there are any casualty like that for them.
I spoke to my NCID colleagues.
Can you correlate?
Yes, I spoke to my NCID colleagues about coagulopathy. They did not see much problems with coagulopathy. And this is maybe because of our population. It is well known that our population has a much lower incidence of, factor V Leiden, protein C and S deficiency, and so on. That's what they believe. I'm not sure, but we did not see much problems with coagulopathy and thromboembolism in Singapore. So, but I'm not sure that's the only reason why our mortality is low. But we did not see much problems with coagulopathy in Singapore. As for the other thing about the community, I remember Alvin telling me that when they swabbed 1.8 million people, right?
Yes.
We only found what
40
cases.
42.
Yeah, I remember very few cases. So I think we have done 3.6 million swabs in Singapore. And honestly, most of these 3.6 million swabs have been the migrant workers. There are 300,000 of them, and we are swabbing them every 2 weeks now, as they've gone back to work, but we're swabbing all of them every 2 weeks, the 300,000. That's how we got the migrant worker population under control. But if you talk about the community itself, yes, we are swabbing everyone with URTI symptoms, with respiratory symptoms, but we're not swabbing everyone randomly, if you know what I mean. So the swabbing is targeted. It is not a sweep across the whole population. So that's the
well, same here. It's targeted, but if it's a health place, then they take everyone. But it's not random. It's not, as you rightly said.
Yes.
We're not doing that.
Yesterday it was announced that they swabbed 5,000 workers at the airport because there was one case among the airport workers, one or two cases among the airport workers. So they swabbed the whole airport staff, 5,000 of them. We're around running about 28,000 swabs a day. That's our capacity at the moment. We're hoping to push it to 40,000, but I think 28,000 is already very challenging because of all the constraints and all the logistics. So to date, 3.6 million swabs are done in Singapore. Yes.
Dr. Chong.
Yes.
Dr. Chang, thank you very much for the very, very good information from Singapore. May I ask you whether all the measures, including the 5 million the tokens that you have been purchasing in Singapore, are they mandatory or voluntary for the citizens to carry? And also the QR code and also the trace together, they are not mandatory or they are?
Okay, you asked a very good question. For example, if you enter any premises, everyone, the people running the premises, whether if you're entering a clinic, the nurses will ask you to do the safe entry, the QR code, or if you go to a mall, they ask you to do a QR code, etc., etc. So the enforcement is actually done by the premise owners. By the way, the premise owners are fined or shut down if they don't follow the instructions. You know what I mean? If there, for example, the inspectors come and find that you're not doing all these things, then the ministry will come and shut you down. So for example, if you're a restaurant, they've closed down the restaurant for a few days to teach you a lesson. So everybody takes it very seriously, especially the people who the premise
I see.
owners, whether is it malls or clinics or shops or retail, everybody takes the rules very seriously. So
I
that's
see.
how it's being enforced. So if
I
you
see.
don't do it, they won't let you in, example.
So it's economically mandatory
Yes.
and indirectly mandatory.
Yeah.
That's good. That's good.
Yeah, they put the onus on the owners of the premises to make sure that you do such things. Yeah, so in Singapore, all the buildings have a station in front or at the various entrances to the building, and all this is going on. Temperature checking, that you click the QR code, blah 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 blah, etc., and you do a safe entry. But eventually, with the tokens, I think it'll become very, very much easier. So much easier. So now the tokens, they have not said explicitly because they haven't have enough for everyone. So they first started with rolling out the tokens to the elderly because it's challenging for the elderly to use mobile phones and so on. So they first started, but they don't have enough for everyone. So until they've got all 5 million out, then they'll start to make it mandatory, if you know what I mean. Because you can't make it mandatory until everybody has one. So I think it's an ongoing.
So now
process.
it's like a pilot phase, and later on it will when everybody has adapted to it, nobody will query about the privacy problems and.
They've been quite reassuring. They've been quite reassuring about privacy. They say they will not intrude on your privacy until you've turned positive.
Dr. Chong.
Yes.
Dr. Chong, what is the price? Can you just give an idea of the token?
Nobody said anything, but I'll try to find out through unofficial channels. I think it's not available. This sort of information is not available. I'll try to ask through unofficial channels.
Is it manufactured?
But how you manage that? How you're managing that?
No,
you're purchasing or
they are getting it from some vendor, obviously, but I don't know the details. I'll try to find out if I can, but
because we have to think whether it's affordable by the countries like us,
sure,
like that. So
it should be manufactured in Singapore, I guess.
Yeah, I think honestly, if you think about it, a swab now costs the Singapore government 100 US a swab. All right. Now I think this token is cheaper than that. You know what I mean? If you think about it, right? If you can use a token at a very cheap price, $10, $10 US or something, hey, it's cheaper than a swab.
Yeah, and not need to be repeated swaps every week.
I think, carry on.
Yes, thank you. In fact, Dr. Chong, the travel bubble, tourism bubble between Singapore and Hong Kong is a nice step, But then in Hong Kong, we are now validating the fast rapid test. I mean, is it replacing the swabbing test? I don't know. But the rapid test is failing in UK because there's a report in UK that they missed 47%. It's ridiculous. So I don't know whether the Oxford one that we are validating, is really reliable or not.
So to update you on this, we are actually also trying to look at rapid testing, including saliva testing, and so on. We're looking at all these different modalities, and it's still under evaluation. I think, when you have 100%, well, I mean, when you have a foolproof test like the swab, and everything, becomes a little bit trickier. So we are evaluating the saliva test and the rapid antigen testing. I think the rapid antigen testing, President, if you can correct me, is similar to the NS1 in dengue. Is that right? Yeah, it's a fragment of the RNA. Is that right?
It is a spike. Rapid antigen test detects the spike antigen.
Yes.
And the RNA detects the genes. So this is the antigen.
That's right. That's right.
In antigen, we have two antigen, S1, S2, S1, S2, and RBD. So any four can be a rapid antibody test and rapid antigen test.
Yes, I think we are evaluating those in Singapore, especially because in trying to open our economy, for example, we want to actually, for example, if we host a conference, we'll do rapid testing at the conference every day, for example. You know, so we really, really desperately need to open our economy. Really depend on the region. You know, we are a very small place, and it's an economic imperative now. Thank you.
Dr. Chan, may I have a question for Dr. Agarwal? Dr. Agarwal?
Yes, yes, please.
Yeah, thank you. Just yesterday, I've gone through the one of you email, and there you have marked about ivermectin, which actually it was conducted in the AIMS, and I have gone through that FT also. That actually it was not in detail actually there. So could you please tell us that was it a systematic?
I'm still finding out. AIMS Bhubaneswar has come out with a study. I'm still trying to trace the original study where they said they have found it effective as a preventive medicine. I'm still looking at their original report. So I will be able to get it and send it to you.
Yeah, thank you.
AIMS Bhubaneswar has conducted a study and they said ivermectin as a preventive medicine works. So that is being a stamp of AIMS, it becomes credible because AIMS is the #1 institution in the country. But I have yet to get hold of the study. It came in the media.
Yeah,
excellent.
That's
Yeah, Dr. Agao, I'd like to share something from Hong Kong. First, I think there's a problem in Hong Kong recently out of the exemptions of testing for those VIPs, those people in the Council Generals of different nations coming to Hong Kong. They were exempted from testing and quarantine when they enter Hong Kong. So I don't know whether other nations have similar arrangements. In Hong Kong, we found that every month there were about 40,000 people entering in Hong Kong without testing of the COVID-19 because of their positions or because they are exempted. In Hong Kong, there are 33 groups of such exempted people entering Hong Kong. And this is a loophole. And that's why in Hong Kong, local cases still linger. We perhaps might have about less than about 10 confirmed cases locally every week. And of course, the imported cases are much more, but then still we have about 1 or 3 every day. And then that is not good, of course. And some with no origin, with unknown origin, cannot trace them. Now, I think these exemptions of testing and quarantine in entering Hong Kong creates the problem. And secondly, of course, some are illegal. Some illegal workers coming into Hong Kong, say as a tourist before, and then they overstayed, and then they are in fact prostitutes. Some from mainland, from Thailand, etc. But these are providing sexual services in Hong Kong, and yet it's difficult to trace their customers. They don't have the names and identities of their customers, and nobody will admit that they had visited these prostitutes, of course. So these are also, again, some sources of our spread in the local community still. So although we only have single-digit confirmed cases every day, and majority are imported cases, but still there are 1 or 2, and then still you linger on with that. So I just don't know whether other nations do you have such a problem. And then, of course, we hope we are in the same boats of Singapore. We long to have the economy revived, of course, and we need to have the cross-border travel between mainland and China, Hong Kong especially. Still, that is not yet optimistic yet. And many people mocked the government. Why you start the travel bubble with Singapore and not doing enough efforts to communicate with mainland China. You know, the controlling power is not in Hong Kong, you know. But anyway, so may I have your expert opinions? What happened to your nations when there are exemptions, when there are the VIPs and the consul generals, etc., coming to your place?
Kindly go ahead, Dr. D'Souza. You'll have to unmute.
Meanwhile, in India also we have an app which anybody can download in their cell phone. But then every day you have to update your position, whether you have a fever, sore throat, or you have a contact. And on that basis, you will get information that within 1 meter, how many positive cases are there. So, but then here the cooperation of the individual is very essential. Only if you are updating every day truthfully these data, then of course you are safe, you know, within 1 meter how many persons are positive, and the rest of the data will be available. And this data, cumulative data, is analyzed by the government, and accordingly the instructions are given, and home quarantine or isolation or admission, all those things are decided on the basis of what you upload in the app. So that definitely is effective in our country. Regarding the increase in the number of mortality, naturally, countries like ours, where the infrastructure, healthcare infrastructure is not very strong, when the number of cases increase, naturally the mortality also is going to go up. But still, in India, the mortality we could sort of reduce up to 1.5% of the total positive cases. That again, we feel that in country like ours, it is encouraging. Regarding the testing, RT-PCR test is the gold standard, and this is the first test that is done by the government whenever somebody has symptoms, and also for random sampling. But then after a week or so, when the symptoms subside, then the rapid test is being done in those persons. And antibody test is being used for serosurveillance as to find out what is the percentage of population which has become immune, which will definitely help us. But this again varies from city to city. Cities where there have been quite a number of cases, the antibody test positivity comes even up to 40%. In cities where the number of cases have been less, the positivity, the antibody testing positivity is maybe 5% or 10%. So that variability across the country definitely is existing. And regarding the microembolism and high fibrinogen content, or as KK has already pointed out, anticoagulation is the standard treatment that is being given on the basis of CRP and D-dimer. And to start with, heparin, fragmented heparin is being used rather than oral anticoagulants. And once the symptoms subside, then of course switched on to warfarin or other anticoagulants. But initially, or at least for a few weeks, the patients are continued and subcutaneous injection, rapid acting anticoagulants are being used. And that has been found to be effective. And steroids role comes a little late when there is cytokine storm, which is diagnosed on the basis of ferritin, serum ferritin level, and oxygen saturation and other parameters. Over
Anybody
to
who is well versed with the races in the world? Is there anybody who has seen a difference in different races? Can we explain the mortality and other things? Anybody who has done it, studied it well? What is because we are getting different standard patterns, Saudi Arabian countries, then we have India. We can divide them actually looking at a pattern. If we can see the patterns and try to see, do they correlate it with some racial pattern, then we may be able to get some answers.
KK, in UK, they've had a whole big report about it. I just received it, where black and brown have been certainly getting higher mortality, and in fact, there was a whole inquiry, and what's his name, Bapio, J.S. Bamra spoke about it 2 days ago in one of our at our meeting with O.P. Kalra. He spoke about this inquiry of unusually high black and brown in UK. I don't know if you heard, but there has been a big inquiry into this, and they've come out with some report on. So I don't know what the.
So I'm really trying to say is that we pick up a race and try to see their response in every country. That's what I'm trying to find out. Suppose if I black and brown, then in every country, are they different? Are they behaving the same? So
it is mainly dependent on the density of population. That is
Yes,
one
and there are other factors.
Yeah. Then second, of course, for developing countries, particularly in India, infectious diseases are so much common that BCG and anti-worm treatment like ivermectin and other vaccines and even hydroxychloroquine are very common for malaria, are very commonly used. So all these definitely boost the general immunological status of the person. And this could be one reason why the infection, if you look at the population, on the basis of the population, infections are less, and our cure rate is almost 90% now. And mortality is 1.5% and is still coming down. But then the cases definitely are going to be more because of the sheer number of the population. And even this number of cases are mainly contributed by 6 states where the density of population is very high, and particularly in the cities. If you go down to the rural areas, the incidents are very less. So that's why we are still in a climbing phase, phase 1 itself, because the population affected is fragmented.
No, this is not the question of actually effectivity. This is because of the severity and this. And actually, you know, in Bangladesh, they have tried to attribute it to the type of the mutated gene actually. And so I don't know what
But
about
still,
the other countries.
even these mutated genes and all, its correlation with severity of infection and its capacity to spread to more people have not been validated. So we are still in a darkness as to whether the mutation is going to be to have a positive response or a negative response.
So D614G mutation now covers 99.9% of the population. So the whole population in the last 2 months, the virus now has taken over as D614G single point mutation. So everywhere it is the same, which is more infectious, less ventilator requirement. That's what it is there. But the question we are basically talking about it, we are trying to find out the answer. The purpose of CMAAO interactions are to find out the answer, because the answer will come from the Asian countries, I'm sure. The answer will come from CMAAO. CMAAO has to, our results are different than of the West. So therefore answers have to come from here. We need to share more data, and we need to think laterally to come out with some answers. At the moment, we all are relying on the Western data. Every day we say America says this, Europe says this. We should only be talking about India says this, Bangladesh says this, and Pakistan and Singapore says this. If you see here, China, Taiwan, Singapore, Korea, and Hong Kong. They are the best results. And if you see amongst India, Pakistan, and Sri Lanka has the best results. So we have to find out our own success stories than to believe on what West is doing. And that's what my intention for the last 30 weeks. We are only talking about why are we protected so much? I mean, all the theories are there in the media, but we are still trying to work upon commonness. Why Kerala is behaving more like a Sri Lanka? In India also, we are saying Delhi has 3 waves. No other state has 3 waves. So I'm only trying to say is that I'm not deeply connecting myself into the races in Asian countries. Amongst the Asian countries, if we can have among the Asian countries, if we can have different types of races, and if we can come back to a pinpoint, which one is behaving what way? Like Chong said, that we don't have a problem of hypercoagulation. If that's so, maybe the whole population of China, Hong Kong, Sri Lanka, Taiwan may not be having a problem of anticoagulation. If that's so, we have at least some answer. That answer gives us is in those populations where hypercoagulation is important, it is treatable. It is treatable.
But
We'll also go through factor C, factor S, and factor 5 later on today to find out in which communicate it is high. So somewhere or the other, we have to find out our own answer. We have to create literature and not look at the literature. So I want Dr. D'Souza to sum up, because we already are late. At 11 o'clock, I have a parallel session.
Yeah, well, we had we started with the graphs, very informative graphs that Dr. KK had put out, having a look at the different waves and the patterns that seem to be coming out from the Western countries, the CMAAO countries, and so forth. And then we went on to have Dr. Chong, who very detailed, gave us a good grounding and understanding of what's happening with Singapore, and including in what do you call it? Not the app, but you had a wallet or so that they brought out, and sounds very interesting how that works. And then of course I briefed on what in Australia, what they've had no cases and it's come down, and we've got another app that's being used which works on Bluetooth. And of course Dr. KK was keen to point what evidence do we have in terms of ratio. Are we getting any picture that there's one particular race is something? I mean, I did talk about United Kingdom, where they have identified that the black and brown seem to have a worse prognosis, mortality, and so forth. And I think very rightly Dr. KK has brought forth that we need to bring our region, the successes and all that should be focused on looking at what's the reason, and how can we emulate that and make this out, rather than only listen to what's happening in Europe and West. Very, very important that part of it is. So we'll focus more on understanding what's happening and the successes of our region. Right? Thank you very much for that. And I will now thank Dr. K.K. Agarwal, thank all of you for making this and also we had, I forgot to add, David Barbie, the new WMA president. He gave a very nice reference to what CMAAO and Dr. K.K. Agarwal has, and all of us have been able to do, coming here for 30 continuous weeks, talking about this, and it looked like it was the envy of the other part of the world, where they've not been able to achieve what Dr. KK and as the president of the CMAAO has been able to achieve here. So congratulations to all of us for that, and to Dr. KK Agarwal for continuing to spearhead this very important meeting every Saturday.
May I request Dr. Agarwal to have a topic, the topic for the next meeting, maybe the antibiotic treatment?
We'll pick it up
treatment?
racial, different Asian races and their mortality, and so each one of you pick up racial communities in your area and find out, is there a difference in ethnicity and COVID-19 mortality and cases?
Okay, thank you.
May I request you to give us some information what your national approach to exemptions of testing is next week?
Yeah.
Thank you.
Just one more thing.
Okay.
I communicated with Dr. Otmar, and he said our timing was a bit tough for him to join us. So,
Yeah.
so he sends his apologies. Thank you.
He can give us also some sort of message like that the Dr. David Barb has given. Same thing. Yeah. Like, thank you.
Okay. I asked him to send us
Something like
clip
that.
or something. A clip. Yeah.
Yeah,
All right. Thank you. Thank you, President.
Okay.
Always
Thank you.
always appreciate this session, and thank you, Dr. D'Souza. Many thanks.
Welcome and great to be with all